Good morning and hello everyone. Welcome to another edition of the Hindu Wellness Series webinar. This edition of the webinar is presented by Kauvery Hospitals. Today we are going to discuss an important topic, which is stroke and the golden hour. We know that we are seeing increasing prevalence of stroke and even younger population is often getting affected. We have also often heard about the term golden hour and the importance of ensuring medical attention for a person suffering a stroke within that golden hour period. But most of us may not have a very clear or better understanding about the topic. That is why we have two eminent doctors from Kauvery Hospitals with us today to throw more light on the topic for us. Let me introduce our panelists for the day. We have Dr. Pritika Chari, who is a very senior professional with nearly 5 decades of practice. She is presently the senior consultant neurologist, neurosurgeon, and chief neurologist at Kauvery Hospital in Chennai. Considering her decades of experience, there is a lot to be said about her, but I'm going to keep it slightly short due to time constraint. So she served in Madras Medical College for about 8 years from 1974, then at Apollo for about 28 years. Now she is with Kauvery Hospital for the past nearly 10 years. In 1994, she started Epicenter, which expands as Epilepsy Institute and Center for Treatment, Training, Research and Education. She was the first one to introduce video EEG in private sector in southern part of the country in 1994. Apart from her medical practice, she is active in carrying out community-oriented initiatives through her association with other organizations like the Rotary Club, Madras Management Association, and Intercultural Women's Association. She has created several awards and carried out initiatives for empowering women and economically underprivileged. She has organized numerous conferences. She is also a master neuro-linguistic programming practitioner, a certified soft skills trainer, an image consultant, and life and brain health coach. We are very happy to have you, Doctor. Welcome to the webinar. We also have Dr. G. Jose Jasper, again a very senior practitioner with nearly 2 decades of neurosurgery practice with us today. He is now heading the brain and spine surgery at the department at the Kauvery Hospital in Tiruchi. He is very keen about newer advances in stroke management, neurovascular surgery, and keyhole surgery of brain and spinal cord. He is very attached to his hometown. He is very committed to bringing the best medical practices across the globe to his hometown, which is what he is doing at the moment at the Kauvery Hospital in Tiruchi. He is also very passionate about music, reading, and traveling. We're very happy to have you, Doctor. Welcome.
Thank you.
So the format of the webinar is going to be, we'll have 2 presentations by our panelists, and after that, we will take questions from the audience who are joining us today as well. So let me request Dr. Jose Jasper to go ahead and make his presentation first. Please, Doctor.
Yeah. Okay. Good morning, friends. First of all, I'd like to thank Hindu for giving us this opportunity to reach out to a very wide audience today. My topic for today is actually stroke, the golden hour, and I'll be highlighting lots of points about this. Now, every October 29th is celebrated as the World Stroke Day. The theme for this year is Save Time, Save Memories, and Save Lives. So why do we celebrate a World Stroke Day? We celebrate it so that, 1, we can educate people about it, 2, increase awareness about it, and 3, bring in the good news that stroke is eminently treatable. Now, going on straight into my talk, a stroke is basically a crash which is waiting to happen, which means it is definitely stoppable and treatable. I think that is the main message we have to carry to our homes today. I would like to highlight about 1, what is a stroke, how to identify different types of stroke, can we as a layperson predict a stroke, and if we suspect a stroke, what do we do? What are the treatment options that are available, and what can I obviously do to prevent a stroke? So that is basically what I'm going to highlight today. So the first question is, what is a stroke? A stroke is an acute vascular event. In the sense, a stroke, either there is a block to the blood flow to the brain. This occurs almost 80% of the time. So if there is no blood flow to the brain, that brain starts dying. And we call that as a ischemic stroke. So you can have a block to the brain, or you can have a bleed inside the brain. A bleed occurs maybe 15% of the time, and we usually call it as a hemorrhagic stroke. Now, bleeds are common, most likely in patients with untreated or uncontrolled hypertension. So these are the most commonest causes of stroke, either a block leading to no blood flow to the brain, or a bleed causing flow of blood into the brain, thereby damaging the brain cells. And very rarely, you can even have what we call as an aneurysmal rupture. So if, like, we have all used bicycles at some point of time, if the bicycle tire becomes weak, we see that the sidewall will bulge, and at one point it will break. So this is an aneurysm like that. The vessel, because it is weak, starts ballooning, and once it is really weak, it ruptures into the brain, most of the time killing the patient. So how do you identify, is it a stroke? It's very simple. You just have to know this. I think this must be the highlight of today's meet, because without awareness or without education, we'll never be able to treat stroke on time. So we just have to remember fast. Look at the face of the patient. It might be your neighbor, it might be your relative, it might be a stranger. Look at the face. If there is a deviation of the mouth, if there is an uneven smile, you know there is something happening in the brain. Then ask them to lift both the arms. If there is weakness of one arm, then you know there is a change in blood flow to the brain. Or ask them to talk. If their speech is not clear, if there is slurring of speech, then we call it a stroke. So never forget fast. Look at the face for any uneven smile or a asymmetry of the face. Look at the arm for any weakness of the arm. Look at the speech. And if you have any of these problems, obviously it's time to rush the patient to the hospital. So the last T stands for time and test. So face, arm, speech, test. In which case, even if one is positive, time becomes important and you have to rush the patient to the hospital. Rarely, you can have problems with balance and eyes also. So in that case, we call that as a be fast. This is seen in case of a posterior circulation stroke, or when the small brain is affected, the cerebellum or the small brain. So balance and eyes, if they are affected, then we call that as be fast. Simplest thing would be to never forget fast. If we can remember be fast, it would be nice. So always remember face, arm, speech. I'm highlighting this again because this is an important carry home message. Now, can you predict a stroke as an individual, as a lay person? Yes, there are warning strokes or red flags that come. And if we can learn to pick up the warning stroke or the red flag, we can definitely avoid a stroke. I've already told you there are two types of stroke. One is a block, one is a bleed. So the patient with a block can have a warning temporary stroke, and a patient with a bleed can have a warning sentinel bleed. So what happens in a temporary stroke? The patient can have a minimal weakness, change in speech or vision. This is very often, and what happens is most of the time the patient says, like, I am normal, maybe I slept on the wrong side of the bed, my position was wrong, and that is why I had this, and they leave it. Most of the time, these weaknesses improve over a period of time, and by a day, they are almost always normal, and we tend to forget it. So a temporary stroke can present with change in face, change in vision, change in speech, or a weakness, but usually it is short lasting. Now, this is basically a warning that there is some block which is either present in the blood vessel, which is supplying blood to the brain, or even from the heart, which has traveled along the vessel and it is blocking the blood flow to the brain. Now, 1/3 of these patients will have a severe stroke within a year. This is an important number to remember, which means if you pick up a patient with a warning stroke, you can stop a life-threatening or a lethal stroke in 1/3 of the persons. The same thing will happen in a bleed also, a hypertensive bleed or aneurysmal bleed. Very often, weeks before a major bleed, the patient will complain of a very severe headache. The patient wakes up at 4 or 5 in the morning, he gets ready to run, and he goes for his jog and comes back, sits down, and he gets a very severe headache. The headache lasts only for 1 to 2 minutes. At the end of it is normal, but after that, he can have neck pain. Rarely they can have even loss of consciousness. There are two things you must remember. One, the headache will be very severe. We call it as thunderclap headache. And the person will always say, I have never had a sort of this headache like this before. And this neck movement restriction is also a good thing, which we must never forget. Again, the importance of this is almost 50% of aneurysms will have a sentinel or a warning bleed. Okay, so we know about all these strokes which present with either weakness of the arm, face, speech, vision, and all that. But there is something known as silent stroke also. Silent strokes will affect parts of the brain which are not directly involved in speech, vision, motor, etc. And what happens is, for every one person who comes to us with a stroke, with an eloquent stroke or with weakness, etc., 14 will have a silent stroke. So this also needs to be evaluated very carefully. Only thing, if you spend time with the patient, usually we can pick up changes in memory, behavior, cognition, and emotion. So it is very important to spend time with the patient, see if there is any changes in memory, behavior. A patient who is very happy-go-lucky suddenly becomes very dull and apathetic. The patient starts behaving differently. He becomes depressed out of proportion to his circumstances. And all these are things which normally we'll say is very common in our elderly, and we do not actually take them to the doctor. So the importance is, if there is any change, if the person is not who they were before, then definitely they need a small evaluation. So, okay, we are thinking of a stroke. Now, a neighbor or a friend or a relative has a weakness or has some speech involvement or has some vision loss. What do we do next? You are thinking of a stroke, obviously, in which case, this is another score to remember. Always remember, if the person is aged more than 60, BP is more than 150, and duration of weakness is more than 10 minutes, and you can make out a clinical deficit, sugar is present, then 1/3 of them will get a stroke in a year, 10% within a week. We call this, the neurologists call this as the ABCD score, but this can be used even by lay people because it tells you the chance of developing a high risk stroke. So age, BP, and diabetes are things which you must always keep in mind when you see a patient with weakness. So what do we do in a patient with suspected stroke? Obviously, you have to rush them to a comprehensive stroke care center. We all know there are hospitals and more hospitals, clinics, specialists, super specialty hospitals. But the important thing is, in patients with stroke, a comprehensive stroke care center is where you must go. So what is a comprehensive stroke care center? A comprehensive stroke care center is designed in such a way or functions in such a way that a patient with stroke always comes first. He is given priority for imaging, priority in treatment, and everything is documented right from the time the patient steps in to the patient leaving the ward or the hospital. Every minute is documented so that we know that we are not wasting time. Apart from this, a comprehensive stroke care center must also have a full-time neurologist, obviously. A neurosurgeon must be available. An interventional radiologist must be available. CT and MRI must be available. And we know all this. But apart from all this, a cath lab or an angio suite must also be available, because nowadays patients with stroke do not need only CT and MRI. Very often they end up landing up in the cath lab, similar to a patient with a heart attack. When a patient comes to the hospital with a heart attack, he is taken straight to the cath lab. And lots of times patients with the brain stroke also end up going to the cath lab. So a cath lab also is mandatory if the center has to call itself a comprehensive stroke care center. So when the patient comes into a comprehensive stroke care center, what happens? Obviously, the stroke code is activated. The patient is seen at once, and a CAT scan is what is usually taken. Now, the neurologist might decide on an MRI, but very often a CAT scan is done. One, because it is very easily available. and it takes just less than a minute to do a scan, and interpretation is easy. MRI also has a very important role, but MRI is usually decided by the neurologist depending on their clinical profile of the patient. So what do you see in a CAT scan? Most of the time, a CAT scan is normal because the brain cells have still not started dying. They are just becoming metabolically, dangerous. They are trying to sort of salvage themselves, and they are slowly starting to die. So early CT scan does not pick up any changes in the CT scan of the brain, but it tells a lot of information to the neurologist so that they can plan on their treatment. So this is a ischemic stroke where literally you see a normal CT scan. This are two images. The one with the black arrow is showing an intracerebral bleed or bleed inside the brain, and the second is an aneurysmal bleed. So why is it important? The neurologist, when they see this scan and this scan, they decide on the treatment, because the treatment for both are diametrically opposite. You cannot treat a ischemic stroke like you treat a hypertensive or a hemorrhagic stroke, and you cannot treat a hemorrhagic stroke like you treat a ischemic stroke. Now, we have made a diagnosis of a block of the blood vessel. What must you do next? Obviously, we have to break down the block, because this block is not letting blood flow into the brain. Now comes the golden hour. The golden hour is not the mandatory 1 hour, but here it is 4.5 hours. 4.5 hours from the onset of a stroke is what you must always remember. So if the patient is able to come to the hospital as soon as the stroke event starts, within 4.5 hours, if the CT is normal, then the neurologist will decide on treatment to break the clot and get the blood flowing. Now there are two drugs, RTP and tenecteplase. Both are available now. Which drug is better for the patient will always be decided by the neurologist. So what does the drug do? It is basically a magic bullet. You can see a clot on the left side, preventing flow of blood distally. When you give this drug, it breaks down the clot or lyses the clot, and we call this as thrombolysis. So it breaks down the clot and blood can flow to the brain. And only problem is this must always be done within 4.5 hours, because after 4.5 hours, the drug's side effects or complications are too high, and it can even cause risk to the life of the patient. So this 4.5 hours is the magic golden number we must always remember in a stroke. Which drug, like I already said, the neurologist will always decide on which drug is better for that particular patient. Once you give the drug, 60 to 70% of the time, the patient will become almost normal. If the patient improves, nothing else has to be done. Supportive treatment, again, under expert care of the neurologist. If the patient does not improve, we shift the patient to the cath lab. So what happens inside the cath lab? Inside the cath lab, what we do is, like you do a catheter procedure for the heart, angio for the heart, we first give a dye and see where is the block. Here you can see the red arrow that is showing you there is no flow of blood in that part of the brain. Then once you have localized the clot, we know the clot is there, we take a special catheter, take it all the way up there, and we mechanically remove the clot. It's a mechanical procedure, and we call that as a thrombectomy, a mechanical thrombectomy. There are lots of devices. Common device is a device known as solitaire. So using the solitaire, we take it to the clot and mechanically remove the clot. That is what you are seeing here. The clot is being removed using the solitaire device. Once you do that, now you can see the green arrow. There is a very good flow of blood and the patient becomes normal. This is just to show you a comparison between the red and the green, because a picture is always worth 1,000 words. Here you can see there is very little flow on the left side of the brain, and the next green arrow shows good flow. The patient made excellent recovery and went back to work within 3 to 4 days. So that is where mechanical thrombectomy comes in. Now, mechanical thrombectomy is a game changer. It is available in all the comprehensive stroke care centers. And if the patient gets an option of that, we must obviously never miss it out, because stroke after the golden hour, treating it is very difficult. Now, like I already told you, thrombolysis is usually done in the first 4.5 hours. Mechanical thrombectomy, depending on the MRI finding, the clinical status of the patient, and obviously depending on the neurologist field, we will do a mechanical thrombectomy up to 6 to 12 hours. Very, very rarely, even up to 24 hours, we can still do a mechanical thrombectomy. So time is important. And if we miss the first 4.5 hours, if the patient comes late, still mechanical thrombectomy might be able to give them back their life. And like I told you, a thunderclap headache is seen in an aneurysmal bleed. Here, the patient will always say they have never had a headache like this. So if the patient gives the history of sudden onset of headache, minimum is a CT scan with angiogram if possible. So a thunderclap headache, neck pain or neck stiffness, and when you ask them to bend the neck, they'll find it little difficult or stiff. So once you do that, you do a CT angio, and you can find out there is a small ballooning of the vessel, a small aneurysm that is present, and this aneurysm can either be opened and clipped, or it can be coiled using the catheter. So both options are available, and both of these can actually save the life of a patient. So how do you stop a stroke? We know the answer. All of us know the answer, but we are too lazy, or we just lack the initiative to do this. So healthy diet, active lifestyle, stop smoking, stop alcohol, decrease stress, control BP, and control sugar. This is the message we must never forget. Food, obviously, eat lots of plant-based food. Lots of veggies are good for health. Avoid processed foods. Lots of salt and sugar must be avoided. Fish and poultry can be used instead of red meat. We can use lots of seeds and nuts in our food. Processed food is definitely bad for health and must be avoided. Exercise, the minimum is 30 minutes a day for 5 days a week, which is 2.5 hours a week. That's all. It is not much. You can do 15 minutes in the morning, 15 minutes in the night, or even 10 minutes in 3 sittings, but at least 30 minutes of exercise per day for 5 days a week. 150 minutes a week is what you must not forget. Stop smoking, because smoking will always increase the risk of stroke and of a heart attack also. Another thing we must remember is second-hand stroke. For example, if the husband smokes, the wife has an increased chance of stroke of almost 30%. If the father smokes, the risk of stroke in children goes up by almost 30%. So no smoking, and alcohol must also be stopped. Some people say that we can use a minimal or a moderate amount of alcohol, but again, recent studies say no alcohol is always better than small quantities of alcohol. Decrease stress. Very true, especially with our modern lifestyle, with COVID, with working from home. Yes, stress is there, very high up in the list. Breathe deeply, meditate, yoga, pray, use music to improve your mood. Keep moving. Even when we are working, they say once in 15-20 minutes, if you can get up and walk for 2 to 3 minutes, it decreases stress. Stop alcohol. Alcohol actually indirectly increases stress. Brighten up your workspace. Keep flowers and plants. Make it colorful. Avoid multitasking. Multitasking is not good for the brain. And learn to say no. You must always know your limits. You must always know when to say yes and when to say no. Control BP and sugar. This is a problem that we see in India. Most of our patients do not want to do this. They say even with high BP, nothing happens. I'm very healthy. I'm very active. So they do not take their drugs, which is why we have a very high incidence of bleed inside the brain. Sugars also affect our health and must be controlled. And when you do your master health checkup, when in doubt, we normally ask for a serum homocysteine level, which is a nutritional sort of a thing, a metabolite in the body. And if there is problems with homocysteine, we just have to give some folic acid. And as part of health checkup, very often we ask for a carotid Doppler also. A carotid Doppler is nothing but the ultrasound of the blood vessel going to the brain. And if it shows a block, preventively, we can do either open surgery to remove the block or a stenting to actually open out the block. So these are all small things, preventive things which you can do to prevent a stroke. The main carry home message is stroke is in India. As Indians, we have a high risk of getting stroke. 1 in 6 will get a stroke. Stroke is preventable. Control your BP, control your sugars, check homocysteine if in doubt, maybe do a Doppler, meet the neurologist, spend time with them. Stroke is treatable. Remember the time 4.5 hours, never waste time anywhere. Remember cath lab, without cath lab, there is not much anybody can do. And never forget fast. Face, arm, speech test is mandatory. Never forget that. On behalf of a Kauvery Brain and Spine Center, we all say thank you for this opportunity. And always in stroke, remember, only time matters, nothing else matters. Thank you, dear friends, for this opportunity.
Thanks a lot, Doctor. That was an excellent presentation. You explained to us in very simpler terms that everybody can understand. Thanks a lot for that. Now, may I invite Dr. Kritika Chari to make her presentation. Over to you, Doctor.
Good morning to everybody. Vanakkam from Chennai. Dr. Jose has been extremely clear and simple and conveyed all the basic facts about stroke. So I am going to actually focus on a completely different aspect. He's told you all the general factors. I'm going to talk about, can stroke occur in a baby, in a child, in a young adult, and I'm going to focus a little bit on stroke in women. Now, if we look at the stroke incidence worldwide, you'll find that India is pretty high. We've got 101 to 125 per 100,000 strokes happening in whole of India. So as Dr. Jose already highlighted, India is quite stroke prone. And another important factor which we have noticed in India is that normally age above 65 is a risk factor for stroke. But in India, we very often see it even in younger people. He has already told you the importance of remembering fast and, if possible, remembering be fast. We cannot reiterate this even 100 times if we say it. It is still worthwhile because this is what the public have to remember. If they see anybody having a facial asymmetry, a weakness of the arm, slurred speech, any balance issues, any coordination issues, any sudden loss of vision in one eye, etc., time is absolutely mandatorily the most important thing you have to think of. So time is brain. So the sooner you get that person to a comprehensive stroke care center, as Dr. Jose highlighted, the more you will be doing to save not only the person's life, but also consequent disability. The bad thing about neurological illness is that many of the conditions we see in neurology are associated with disability. And when stroke disability occurs, you're looking at long term, anywhere from 6 months, 1 year, 2 years, and sometimes no recovery at all in the paralyzed part of the body. So it is worth preventing that. And if we can rescue them in that first 4.5 hours, as he mentioned, nothing like it. So in young people, stroke symptoms can be overlooked. In fact, there has been a lot of discussion on this all over the world, that though the symptoms are very similar, whether it is in a person who's 65 plus or a younger person, when a younger person reports to the ER with a sudden numbness or weakness of the face, arm or leg, especially on one side of the body, or a sudden confusion, trouble speaking, difficulty in speaking, vision problems in one or both eyes, trouble walking, dizziness, loss of balance, coordination, Very often in a younger stroke, we find that headache is a more common symptom than we see in strokes in the older patient. Also, there may be subtle symptoms like vertigo. They may just feel very dizzy, the room is spinning, or they may just have little imbalance. And the slurred speech may not be for words. It may just be a mispronunciation of the words. Sometimes they will not find the right word. We call that word finding difficulty. They may sometimes have double vision, not just loss of vision, and nausea and vomiting with a headache. So it can get mistaken for many other things, especially in a younger person. And remember that the symptoms depend on the area of blood supply. So what we have talked about in FAST is mostly the front part of the brain, arterial blood supply, which is compromised, which can cause those symptoms. When the posterior circulation, as you already mentioned, is affected, the B part of it, of B FAST, comes into play. Imbalance in coordination, all those things come into play in that part of the brain supply. So the symptom depends on the area of the supply and which blood vessel is blocked or has bled. He has already highlighted what are called mini strokes or pre-stroke or transient ischemic attacks. So the significance of this, the importance of this, he has already emphasized. I'm not going to repeat this, but I want to reiterate the fact that you have to remember that a pre-stroke is as important for you to see the doctor as it is when you have the early signs of a stroke. So if it is B-FAST or not, even a pre-stroke becomes very important for you to go to the doctor. I'll tell you why I'm emphasizing this. See, though these symptoms are very short-lived, the tendency, if it lasts only 1 to 5 minutes, is for us to neglect it and say, oh yeah, I felt uneasy. It happened because I was tired. I went out in the sun. I did extra work. I was a bit stressed. All of these excuses we give ourselves when we get a TIA or a mini stroke or a pre-stroke. But what is important is you have to go and see the doctor who will do a physical examination where your pre-stroke may have left behind some neurological deficit which they can pick up. We call that as recurrent intermittent neurological deficit. And they will also do some diagnostic tests, like Joseph has already highlighted, a CT scan, an MRI, a carotid Doppler, your blood parameters to check check your blood pressure, etc. The reason why this is very important is we have had patients who have come to us maybe after 1 episode of a pre-stroke or 2 episodes or 3 episodes. And when we advise detailed investigation, they get upset with us. They think we are over investigating them for something very trivial. So please understand, like he has already highlighted to you, that when you diagnose and pick it up at this stage, we can prevent 35% of strokes can be prevented. So please report to your doctor. It doesn't matter if you go to a doctor for something which is not a TIA. It might be something else. It might be a ear problem which is making you dizzy and having imbalance. But it doesn't matter. Let the doctor examine you. Let the doctor do the necessary tests and make the diagnosis. You can prevent getting a stroke. 35% of people can prevent getting a stroke if they are caught at this stage. Because the prevention is important. And like he said, if you have, after carotid Doppler, you have a plaque in the carotid, it can be removed so that little pieces don't break and go to the brain and cause what is called as an embolic brain infarction. So 1 in 3 people who have a pre-stroke will eventually have a stroke. So it's worthwhile you're going to the doctor. Again, we repeat the preventive steps, which are control your blood pressure. What is very, very important in addition to controlling your blood pressure is maintaining a healthy weight. Overweight and obesity are risk factors not only for hypertension and for diabetes, but also for stroke per se. It's very important to keep your blood sugars under control. Understand that if you allow the blood sugar to drop too low also, sometimes that can precipitate a stroke. So please go to your doctor at regular intervals. I would suggest that a diabetic should see their doctor at least once in 6 months. They need to have their hemoglobin A1C, which is a 3-month sugar control evaluation every 3 months. And there are some basic investigations which the doctor will order once a year. Of course, quitting tobacco and alcohol is an absolute must. Now, can stroke occur in children? This is commonly not known. Stroke can occur at any age, but most of the time we are focusing only on the 65 plus and talking about that. So let us take a look at some of these strokes. In a child, when we say pediatric stroke, we mean in children. You can get the same ischemic stroke, you can get the same hemorrhagic stroke that you see, but the cause for these will be different from what you see in an older person. In children, ischemic stroke can occur by blockage of the artery and by blockage of the vein. I'm going to talk a little bit about the venous stroke a little later. And around birth, it's very, very important to know that ischemic stroke can occur in children when there is a birth injury, during birth, during delivery, when there are problems. There can be less glucose, there can be less oxygen, there can be less B6. All of these can cause disturbances in the development of the brain or in the health of the brain around delivery. So even inside the mother's womb, it is possible for a child to have a ischemic stroke. Ischemic stroke means blockage kind of stroke. Neonatal, soon after birth, and around birth. So in all of these, you can get arterial and venous strokes in all these categories in children. Now, among the ischemic stroke, the causes for the arterial stroke are very often associated with cardiac disease. There are some abnormalities in the heart. There may be infections in the baby when it is being coming through the birth canal. There can be injury to the brain. There can be very low hemoglobin or very less RBC hemoglobin. There can be, in a child, even things like chickenpox can cause a stroke, can cause an ischemic stroke because it tends to thicken the blood in the system. Then there are conditions which occur at birth in the arteries themselves. There is it's called arteriopathy, where the walls of the arteries are not normal. There are congenital causes for this. There are also inflammations of the arterial wall. And there's something called as primary CNS vasculitis, where the blood vessels of the brain are abnormally inflamed, even at birth or in young children. Around the venous stroke, there can be blockage in the venous channels, cerebral venous thrombosis. And this occurs due to dehydration, due to infection, and due to certain clotting disorders which the baby may have at birth. In hemorrhagic disease of the newborn is something that is very, very specific to the newborn and can occur in some babies. Also, when a baby is born prematurely, the chances of oxygenation to the brain is less. And when they do ventilation, sometimes it precipitates intraventricular hemorrhages and it can cause a stroke. So a baby can also have an arteriovenous malformation or an aneurysm which can rupture. But unlike the adult, where an aneurysm is more, a connection between the arteries and the veins with weak walls is what ruptures in a baby. If you take stroke in the adult, in the young adult, you'll find that alcohol and smoking contribute to about 9.5% each. Whereas there is a family history of cerebrovascular disease. That means stroke as well as cardiac disease. But remember, in the young adult, look at blood pressure. 44.5% is due to hypertension. 13.9% is due to diabetes. So many people have diabetes in the family, and that can cause a higher incidence of stroke in the young adult. Stroke in children and young adults. I've already listed this. Remember that addictive drugs can also cause stroke. Just give me a minute, please. Go. Cigarette smoking, and most important, I want to focus on, especially in women, are the use of oral contraceptives. Now, anything which thickens the blood, like when we have a very high hemoglobin, it is called a polycythemia. That can cause blockage in the blood vessels. When there are high level of platelets, they are called thrombopathies. They can cause blockage of the blood vessels. Now, all of these are more common in young adults with stroke. When there is cigarette smoking on top of a vasculopathy, it aggravates the condition. When a person with a vasculopathy takes an oral contraceptive, again, it aggravates the condition. The same happens with high alcohol intake. Another thing that has been recently discovered is that if your mother had abnormal weight gain during pregnancy and you were a big baby, you had a high birth weight, the risk of cerebrovascular disease in you increases. So there is also a hand-me-down from the parental lineage, not only of diabetes and hypertension, but also the tendency to get a stroke. So cardioembolism coming from other parts of the body, from blood vessels, from heart, etc. When the arterial wall sort of splits, it's called a dissection. Migraine, some kinds of migraine can be associated with a stroke. Drugs I've already told you, hypercoagulable states I've already told you, and there is an entity known as premature atherosclerosis in young adults, which predisposes to stroke. So the changes that have to happen in the arterial wall in an older age starts happening much earlier. And this can be avoided, can be prevented by lifestyle modification. Now we go to stroke in women. What is very important to understand is, I told you stroke can come from blood clots coming from somewhere else. There is a heart condition called atrial fibrillation, where the heart will beat very, very, very fast, and the upper chamber of the heart will beat very fast. So little clots from there can be sent into the brain like a shower, and that is called cardioembolic stroke. Now, this is more in women than in men. Hypertension itself is higher in women than in men. Diabetes, atrial fibrillation, these are stronger. They create problems in women much more than they do in men. Very, very important is women during pregnancy can develop a hypertensive condition known as eclampsia or preeclampsia. And this can cause stroke in pregnancy. It can cause bleeding in the brain when the BP shoots up very high suddenly and cause an intracerebral hemorrhage. And this can be a leading cause of maternal death. So we have to be very careful in monitoring during pregnancy. And women who have low access to education, who don't know these things can happen, don't go to their obstetrician for a checkup. So again and again, I emphasize, your doctor is there to help you. So please make sure you go for regular checkups during the period of pregnancy, because there are little things, routine measurement of the blood pressure, routine measurement of albumin in the urine, all of which the obstetrician will do, which can actually identify these conditions and prevent complications during the pregnancy. So in women, the predisposing factors could be heart problems like a big heart. It's called cardiomyopathy. Then there is an open hole in the heart called the patent foramen ovale, because from there, emboli can shower into the brain. Sugar, diabetes, hypertension, hypertensive disorders of pregnancy, and the tendency for what is called as prothrombotic states. Here there are disturbances in the clotting factors. And very, very importantly is the venous sinus thrombosis, on which I'm going to just spend a minute or two. Remember that during pregnancy, women have genetic factors. When they're very young, when they have a delivery, when they're a little older, when they have a delivery, when they have had multiple children, when they are overweight, obesity, when they have a very unstable and high lipid levels, when they're physically inactive, and when they drink during pregnancy. All of these are risk factors which can push a woman into the hypertensive disorders of pregnancy. Incidentally, there are also risk factors coming from the father. If this is the first pregnancy between a man and a woman, the likelihood is that there is a higher risk, slightly higher risk of getting a hypertensive disorder. If the man has fathered a pregnancy with preeclampsia, supposing the previous pregnancy had preeclampsia in the mother, that lady has to be monitored very carefully for the second delivery. Then there are also incidental factors in the placenta, which is the birth nourishing organ, which is inside the womb, which comes, it's the afterbirth. After the baby is born, the placenta is removed, and this nourishes the baby when the baby is in the womb. And placenta can have less blood circulation, can have less oxygen, and can have invasion by certain abnormal cells. Now, all of these cause disturbances in the arterial wall of the mother, and this can lead to a hypertensive disorder of pregnancy. So in summary, for a woman, the risk is from the heart, where there's valvular heart disease, atrial fibrillation, cardiomyopathy, and patent foramen ovale. Then there are extracranial and intracranial disease, where you can get aneurysm, where you can get the splitting of the arterial wall called dissection. Intracranial venous disease, which is blockage of the veins in the brain, and the hypertensive disorders of pregnancy. So women are at higher risk, especially during the childbearing age. And this is something we have to remember, because very often we cannot include women in many clinical trials, etc. We cannot include women in clinical trials when they're pregnant, etc., for us to explore the treatment options. So it's very important for us to take care of our women during their pregnancy. Maternal and child care becomes very, very important if you want to prevent stroke in women. And we know that pregnancy by itself is a prothrombotic condition. It increases the risk of stroke. Stroke risk is more in women under 35 and above 35. Important to identify the risk factors. So if we minimize the standard risk factors for stroke, so if a woman maintains a healthy weight during pregnancy, is not hypertensive, does not have diabetes, etc., chances of her having a smooth and healthy pregnancy are very high. Now, these are the veins. The arteries form a network, but there is a complete venous system in the brain which can get blocked, and that is what is called as cortical venous thrombosis. And this can paralyze patients and also kill a woman in the perinatal period, that is around pregnancy, when she delivers. And just after delivery, the risk for this is very high. And this is often precipitated by dehydration. Maybe they have a diarrhea. Maybe they don't drink enough water, various other conditions. But pregnancy by itself predisposes to cortical venous thrombosis. And you can see here that and this can be diagnosed with an MRI. And you can see this is completely blocked. It should be full like this. It's completely blocked here. So there's a new cause for cerebral venous thrombosis, which is COVID. And there have been a multi-center study which has shown that patients with SARS-CoV-2 infection can get into a cortical venous thrombosis. So women are hit in many ways and much more than men, especially in the younger age. So when you have a cerebral venous thrombosis in COVID, this is how the venous infarction looks in the scan. So oral contraceptives, there are some rules. We do not give oral contraceptives to all women. And it's good that other barrier methods of contraception are followed. There are absolute contraindications for oral contraceptives in some people. And this is very important for the public to know. When there is migraine with neurological symptoms, you will not advise oral contraceptives for such a women. Remember that women are more prone to migraine than men are. If there is pregnancy and breastfeeding, do not advise oral contraception. When there's severe hypertension, when there's complicated valvular heart disease, when there's diabetes with vascular complications, when there is active liver disease, when they have just undergone major surgery, maybe even a cesarean section could have been done just recently. So 3 months post cesarean section, do not advise oral contraception as a method of contraception. And prolonged immobilization, if they're in bedridden for a long time, such patients should not be given oral contraceptives. Having said that, we don't want everybody to panic when they hear about oral contraceptives. Serious complications are very rare. If the person is healthy and a non-smoker, there is no increase in stroke, no increase in heart attack, and there is no morbidity which is increased. But there are risk factors like smoking, blood pressure, overweight, diabetes, and an abnormal lipid profile. Then you get a 3 to 4-fold increase in thromboembolism. So what is the first aid you can do if you see a patient with a stroke? We've already told you the be fast is important, reaching them to the hospital. You can check the vital signs, you can check the breathing, you can check the pulse, the consciousness. Keep them maybe propped up like this because they may aspirate their own saliva and choke. If they're unconscious, you can lay them flat and turn them to the side. But placing the emergency call immediately is the first and the best thing that you can do. And make sure that there are no tight clothes, make sure that there's no crowding, keep the patient comfortable. And if the patient is conscious, reassure them so that they don't panic. So after all this discussion, which Dr. Jose and I have done, I think all of you are very, very clear that once a stroke occurs, what we can do is much less than what we can do to prevent a stroke. So he has already highlighted to you the dietary prevention. He has highlighted to you what ways in which the acute stroke is treated. But what I would suggest is, let us all go on to half salt. That's one of the important contributors to hypertension. In fact, there are some places in some parts of the world where in restaurants and hotels, they do not keep salt and pepper on the table. This is one way to reduce the sodium intake because people tend to added salt is a real danger and can aggravate hypertension. Get regular checkups. This is very, very crucial. Please trust your doctor, have faith in your doctor, have your annual master health checkup. And if you have high blood pressure and diabetes, see your doctor at least once in 6 months and anytime you experience any kind of symptom. I think with this, if we have not convinced you that stroke can be prevented if we all work for it together, we would not have done our duty. So I request all of you to start loving yourself, cherishing yourself, nourishing yourself, nurturing yourself, and taking care of your health. And don't make health the lowest priority in your life. Make it the highest priority because health is wealth. And without health, you cannot enjoy your wealth. Thank you very much.
Thanks a lot, Doctor, for that detailed presentation. I think both your presentations beautifully complemented each other in covering different yet very important aspects about stroke. And I'm sure all our participants are very convinced about the preventive aspects that each one of us have to take to prevent strokes from happening rather than, getting treated for that later. We have only a few more minutes left. We can probably extend it by a few more minutes. We have about 10 questions. So probably I will take the audience questions first, and then I can ask some of the questions that I wanted to ask as well. We have Prabha Narayanan asking that what are the chances of having a second stroke after the first one and how to avoid it? Dr. Chari, you want to take it?
Okay. See, the first treatment that we give when we discharge the patient after a stroke is always focused on prevention of a second stroke. Because there is no way, just like a heart attack, once you get a heart attack, you are at risk for getting another heart attack. So the way we have to prevent a second stroke is to, if you have not been following the lifestyle modification, start following all those conditions. If you are overweight, work on reducing your weight. But also remember, soon after a stroke, we cannot send you to the gym and you cannot go for a walk for 22 miles and 5 miles and all that. And also sometimes, especially if you're a young adult or a woman with a stroke, you may have associated cardiac problems. I want to highlight this because what happens is sometimes patients are over enthusiastic and they do excess physiotherapy and land up with a heart attack. So everything you have to take in moderation, but work on it and work on all the risk factors that we have highlighted. So if you're a smoker, stop smoking. If your lipids are high, take the lipid controlling drugs, that statins, which the doctor will advise. The doctor will give you blood thinners. This is to prevent the thickening, the viscosity of the blood, to reduce the viscosity of the blood. The doctor may advise you on certain measures for your cardiac condition if you have one. So follow all those advice, be with regular checkups, and lifestyle modification is the way to avoid a second stroke.
Thank you, doctor. Thank you for that. There is another question from an attendee who has not identified himself or herself. Is syncope a warning or symptom of stroke? My dad had syncope once and we did a master health checkup for him. Did not find any abnormalities. Should we be concerned about this incident? Dr. Jose, would you like to take that question?
Yeah, I'll take it. Yeah. Syncope, there are lots of causes. So obviously you have to be seen by the primary physician. They like to rule out the general ones. If the patient is a diabetic, they might like to rule out low sugar. If the patient has cardiac issues, they might want to rule out cardiac issues. So it can be a presenting symptom of stroke, but it needs a proper workup by the appropriate team, including a physician, a cardiologist, and the neurologist. Very often, all the investigations will be normal, in which case we can be actually happy and safe.
Thank you, doctor. We have another question from Sri Ranjani Ramanathan. Her father had a stroke in November 2020, underwent craniectomy and tracheostomy, and recently had cranioplasty. He also had a second stroke in May. After the second stroke, he is having seizures repeatedly. Now the frequency of occurring seizures is increasing. He's not missing any medicine, but still occurrence is often now. How to avoid it? Dr. Jose?
Okay. I think recurrent stroke, madam has already talked about recurrent stroke. So obviously you need a closer follow-up with your neurosurgical and neurology team. Very often the scar tissues in the brain itself can keep on giving recurrent stroke. And if they are not able to control the recurrent seizures with the right mix of drugs, if they are not able to do that, they might ask for, EEGs to really localize where the seizure is coming from. And if the MRI, the clinical profile, the temporal, the timing, and everything matches, they might advise even excision of the scar tissue to prevent recurrent seizures. So it may be necessary. You will have to obviously work much closer with your neurology and your neurosurgery team.
Right. Thank you, doctor. There are some specific questions regarding, asking whether a consultation is possible, etc. So we suggest that you can reach out to Kauvery Hospital separately to get consultation. We are trying to address more broader questions that will be of interest to more people. There is one question from Riju Dubey. If I plan for pregnancy and having a genetic history of hypertension and diabetes, what tests I have to take before pregnancy for safety of me and my child? Dr. Chari, would you like to take that? Yeah.
See, when you have a genetic history of diabetes and hypertension, the first thing is just get your BP checked. Go to your physician and get your fasting blood sugar and hemoglobin A1C done. That itself is an adequate screen. But since you have a family history, if you are overweight, before you get pregnant, I suggest that you reduce your weight to ideal weight. Second is, you can now itself make your salt intake half, and you can start eating healthier and start exercising more regularly, so that even once you get pregnant, you can maintain some degree of activity and exercise. Don't be afraid, because just because your parents had BP and sugar, there's no necessity for you to get it right now. and you will be quite safe. Don't get panicky by all that I mentioned. That is only if you are not monitored. And so be with your obstetrician, work with them, get into ideal weight, ideal blood pressure, ideal blood sugar level. Things should go well, and best of luck.
Doctor, sorry to interrupt. I think the same person has also now mentioned that she's taking anti-epileptic drugs since 14 years. So does that change any?
That changes things a lot.
Right.
It depends on if she is on safe anti-epileptic drugs, she can get pregnant. There's only 1 or 2 drugs which are safe for pregnancy. So she needs to check with her neurologist. If she has to get permission from the neurologist, if she can get pregnant, because some drugs can damage the baby, and it has nothing to do with her genetic history. It has everything to do with the medication. So you need to check with avoiding seizures during pregnancy is important. So try to work into changing of your medication to the safe drugs, getting your seizures under reasonable control, all this, and then plan your pregnancy together with your neurologist, and see both neurologist and obstetrician throughout the pregnancy.
Some attendees have asked whether the recording of this webinar is available on the internet. Yes, it will be uploaded to YouTube. It is live streamed there, and it will be there for future reference as well. And we have another question from an anonymous attendee. Whether heart patients implanted with ICD prone to stroke? My father at the age of 68 had a hemorrhage. Dr. Jose, would you like to answer that?
Any patient who has any cardiac history itself is high risk for stroke. What we need to remember is a cardiac event, a heart attack or acute cardiac event or acute coronary event itself tells you that indirectly the blood vessels are damaged. Yes. The implantation by itself, chance of a stroke is there. It doesn't go up a lot. Depends on what type of implant it is. We have to really know what type of implant it is. It's a valve or is it a pacemaker? And if it's a valve, where is the valve? Which end of the heart it is? Is it in the right heart or the left? Yes. So we need lots of details, but I'm sure anyway the patient is undergoing a close follow-up with their cardiologist. They themselves will be they'll be able to answer what is the chance of developing a stroke. But definitely a higher risk does exist and they'll need careful cardiology follow-up.
Can I add something?
Yeah,
yes.
please.
If there is an implant, there's a chance they may have put the patient on something called warfarin, which is a drug which prevents clotting. And that may have caused the hemorrhage in the brain. So it's very important for that to be worked with and balanced, because that is commonly something that most people don't know, that brain hemorrhages can occur with the medication that we give to prevent clots from going from the heart into the brain. So you avoid an ischemic stroke, but you end up sometimes with a hemorrhagic stroke.
Thank you, doctor.
You ask your cardiologist, he or she will explain everything to you.
Right. There is a question from Ravi Shankar BG about the effect that I mean, how important are genetic factors in stroke?
I already covered that, no?
Right. All right. There are also a lot of questions about preventive aspects of stroke. I think both of you covered that quite extensively. And let me see if there are. There is a question from Jaksharan Singh Virdi, who has asked, do antidepressants predispose to stroke? What precautions are required for a person on antidepressants? Dr. Chari, would you like to answer?
It doesn't predispose to stroke, right, but stress does.
Okay.
So that means they're not psychologically comfortable. So the stress part of it can aggravate blood pressure, can worsen diabetes, and can also increase the risk for stroke.
Right. I'll throw some of the questions that I had as well, doctors. Dr. Jose, you mentioned about the importance of comprehensive stroke care center and why it is important to take the patients as early as possible to the nearby center that is available. But we know that we live in a country where there are resource constraints, and most of our best healthcare hospitals are concentrated in urban areas. So people living in rural areas may not be able to reach such a center at the earliest. So in such situations, what are the alternatives? Also, I would like you to elaborate on what can the caregivers do? The person who is accompanying the patient who is suffering a stroke, is there anything that they can do to make the situation better? And in the impossibility of reaching a comprehensive stroke center at the earliest, what are the alternatives available?
Actually, stroke is a very lethal and deadly disease. And unfortunately, our treatment options are very few and limited. Even say a couple of years ago, if a patient developed a stroke, nobody used to do anything because they'll say there is no point in treating a patient with stroke. The beauty of at least Tamil Nadu is, I think most of the major urban centers have a comprehensive stroke care center, most of it. And another beauty is Tamil Nadu is very well connected. So less than 3 to 4 hours, yes. Most of the government hospitals now offer thrombolysis. Most of them do offer thrombolysis, like RTPA or that is Altiplase or Tenecteplase is available in the government hospital itself. So if the patient gets a stroke, and if there are problems in, say, reaching a place like urban thing, most of the time the patients can just walk into a government hospital, still be thrombolyzed. And there are 1 or 2 government hospitals also where thrombectomies are done routinely. You can always thrombolize a patient and then shift the patient. It will buy you some time. You can get maybe shift the patient to, say, even anywhere in Tamil Nadu. I think within 2 to 3 hours, you can reach Chennai, Coimbatore, Trichy, Salem. All these are easily reachable places from any corner of Tamil Nadu. Yes, so I think we have to keep our options open. Aggression, there's not much you can do without these options, unfortunately.
Thank you, doctor. Thank you.
And our 108 ambulance service is very good.
Right, yeah. Dr. Chari, I would like you to answer this question. I mean, you reiterated the importance of fast and how important it is to observe the symptoms. But you also told me that people often tend to ignore these symptoms, particularly during the temporary strokes that happen in advance. Dr. Joe spoke about the 2 types of the early warning signals that we can get. One is the temporary stroke and one is the bleeding that may occur, which will result in thunderclap sort of a headache. So I wanted you to answer about the temporary strokes. How severe will that be? Like to what extent the patient will feel that? And particularly you said that younger population tend to ignore it more. So how precautious one should be?
It's a $1 million question with a very difficult answer, because it can be very mild. That is the problem with the pre-stroke or the TIA. It can be very, very mild. It can be a total paralysis of the arm for just 1 minute.
Okay.
So that is why it can be, neglected, not noticed, not paid attention to. That's what you tend to do. Many people do that. The important thing for pre-stroke is a symptom which can get very easily missed is cognitive changes. Sometimes the patient will be temporarily, just for less than a minute or 2 minutes, be mentally confused. That is very, very difficult to find out even for the patient himself. The others may not even notice that he or she is confused for a few. That can be very difficult to identify. So what I'm saying is, it's better to err on the side of going to the doctor anyway.
Right.
Let the doctor say, no, you're unnecessarily frightened, just reassure you and send you if they feel at the end of everything, there's nothing we can pick up. Right. Don't resist going to the doctor is what I would advise.
Yeah, that's a great advice, doctor. Thank you. And I think we are exceeding time. Maybe I had a few more questions, but I'll just ask one more and we can probably wind that up. Dr. Jose, you mentioned about 4.5 hours being the golden hour, but I wanted to ask you, does it also depend on the severity of the symptom? Like if it results in a complete paralysis, should the person be taken to the hospital much earlier, or is 4.5 hours the general rule, irrespective of how severe the symptom is?
I think severity is not very important. Sometimes patient will have a minimal weakness, but the stroke is still evolving inside. So you really do not know. Once it completes a stroke, then we might not really have too many options. So what we call as the golden hour is 4.5 hours, right from onset of the first symptom. The first symptom might be a minimal weakness. It can be a minimal speech change. It can be a minimal double vision, whatever it is. From the onset itself, it is 4.5 hours.
Right.
And
Yeah.
a point of reassurance is
Yeah.
now there has been a little bit of modification. We can stretch in some cases the period to 6 hours. So if people are getting worked up about reaching a comprehensive stroke care center in time, let them do their best as soon as possible. So there are a few cases who might benefit in 4.5 to 6 hours in that window.
Right. Thank you so much, Doctor. I think it was a very great session. It was really informative. And we could see that from the number of questions that we received from the audience, there was a lot of engagement. And unfortunately, we couldn't take all of them due to lack of time. So I apologize to all our audience who connected today for not being able to take all the questions. I once again thank Dr. Chari and Dr. Jose for their excellent presentation and explaining all this to us in very simpler terms that is understandable to lay public as well. Thank you so much, doctors. Thanks a lot for joining us today.
Thank you.
Thank you.
Thank you very much.
Thank you.